Hey everyone, so we are a few minutes to noon, so I wanted to go ahead and get started introducing our speakers and panelists. A big thank you to Dr. David Foley and Dr. Susan Painter, who are going to be our discussion moderators and authors of this really awesome activity. Dr. Foley put a lot of work into making this video really great, and I know that Dr. Painter will provide some really great discussion. So I do have all of the attendees muted just so we can eliminate some background noise. So please utilize the chat box and the question box, and we will get to everyone's comments and questions as we go throughout the activity. So Dr. Foley and Dr. Painter, if you want to just introduce yourselves really quick.
Hi, I'm David Foley. I am currently the Dean of Nursing at Notre Dame College in South Euclid, Ohio, and I'm very recently the Director of Faculty Development and an Assistant Professor at Case Western Reserve University, where I was when I authored this video. I have a background in psychiatric nursing, and I'm looking forward to our discussion today.
And I'm Susan Painter. I'm the lead faculty of the Psychiatric Nurse Practitioner program at Case. I'm also a consultation liaison nurse practitioner, and our goal today is to raise awareness around this very important issue and hopefully have a better understanding when we're completed. Thank you guys for attending.
Thank you both. So now we are going to encourage all of you attendees to click on that YouTube link that you received in your email yesterday. We'll take you to YouTube and the video, Call Me Miss Wertz. I'll give you a few minutes to get over to that screen. Do not close out of the webinar. We're going to come back to this webinar in about 9 minutes or so when the video is done, and we will start our discussion. Hopefully all of you had a chance to start your video. Use the chat box if you have any questions. All right, so hopefully everyone was able to watch the video. I've heard that a few people had some technical issues. We're trying to get some emails to you if you reached out to us, but it was just a YouTube link. So if it's not working, we're not sure what that issue would be. So in the interest of time, we are going to go ahead and get started with the discussion. And I will hand it over to Dr. Foley and Dr. Painter.
So just very briefly before I turn it over to our clinical expert and debriefer, Dr. Painter, I just wanted to share a bit of background in that this video is an amalgamation of a number of patient interactions that I've witnessed in my nursing practice over the years. The video is meant to be very raw and ugly because I think when we have raw and ugly, it can actually prompt some very meaningful discussion. So I hope no one was offended, but I've seen bits and pieces of all of this in my nursing practice, and I decided to author this script one evening just to bring it all together, hopefully to facilitate some discussion. So I guess I'll turn it over to Dr. Painter, and then I will jump in as appropriate. Thanks, Dr. Painter.
Thank you. And from my end, I wasn't having any problems watching the video. It came through very clear. So I just was talking before we got started today about how what great information there was in the article that was posted for everyone to read. And even working with patients and working in mental health as long as I have, I was really affected by the article and just basically how far we have to go in understanding what's going on with our patients. And so I just kind of wanted to open that up to you and see first what you guys thought about the article and then how you could relate to the video.
So Sue, I just wanted to say it's David, that I think that one of the things that jumped out at me from the article, and I found the article long after I actually authored the video, the script for the video, is this concept of dehumanizing and exoticizing that sometimes I think, we really need to be aware when we're on duty as nurses and we're in our role of professional nurses, that even some of the things that we say can be even just very subtly leading to people feeling excluded from their own care, not part of their own care. And when they do that, I think it can lead to adverse clinical outcomes, as was highlighted in this video. Something that was in the video that I think was particularly egregious was the derogatory term tranny. And obviously the patient, even though they were very ill, felt like they had to come over and try to confront this nurse. And I think it was actually quite serious. I'm just wondering what other, breaches of what we would consider anything remotely resembling effective nursing practice were observed in the video as they relate.
So David, this is Jessica. I think that the thing that struck us the most was the fact that this patient was very sick and the nurses were completely ignoring Ms. Wertz's physical symptoms, and they were so focused on the fact that she's transgender that they blatantly ignored the actual illness and why she was in the hospital. And so that just seemed the most egregious to us firsthand, that someone's gender identity issues trumped their physical illness while they were in the hospital for care.
And I guess go ahead, Sue, please. No, I guess from an organizing framework, almost of Maslow's hierarchy of needs, a state board question for, since you're a nursing student, what do you do first? Do you think about the patient's psychosocial condition, or do you go right to the bottom of the hierarchy and say, I have a patient standing in front of me whose oxygen is not even connected to anything, and they're obviously in respiratory distress and coughing and even saying, I can't breathe. What do you do? I think that's a very basic expectation we have that we are going to keep a patient's respiratory status addressed, regardless of what we think about anything going on with them psychosocially.
And I was going to say, I think one of the things that affected me the most in the article and in the video is how invisible our patients feel. And when you add that they have other struggles with coping and may have some depression or anxiety or other mental illnesses, and yet we, in my opinion, we put them in a position of fighting and advocating for themselves, when it should really certainly be us as healthcare providers allowing a safe place for them to land just to begin to heal from whatever it is that they came in for. And instead, it's like we put them in this struggle or this battle to just survive the healthcare experience. And I think that was one of the things that in the video and in reading the article affected me the most. How can we create a safe space and keep it safe and advocate instead of erasing and ignoring what's going on?
And I think too, it's what does the term safe space really mean? Does safe space mean that the nurse has to, absolutely agree with everything about a patient but I think a safe space means, for me, and I'm just going to share my safe space, that I'm going to provide a courteous, safe environment where I provide one standard of quality care nursing to every patient with whom I come into contact. And that includes just basic common courtesy. So as I'm looking at the article, just some of the things in the video, and I'm hoping others in the audience will point out what their observations are. When you look at the Nurse Practice Act, when you look at the Ohio Administrative Code 4723-5 that highlights the rules for education programs, and they have all the things that the students shall not do. We shall not mishandle or misappropriate a patient's belongings. And if you'll notice, one of the nurses held up a red undergarment that belonged to the patient, and she purloined it and brought it to the front desk just to get a cheap laugh. And I mean, starting with something as basic as that continues to go along with poor medical care. Would you go to lunch for an hour and leave your patient not adequately oxygenated? Of course not. So I guess that safe standard of care, I think, just means that, in my opinion, and for me, it's just that, I might not agree with everything that my patients do. I might not feel culturally, I guess, enamored with everything a patient might do, but I do feel a need to provide a safe, quality, competent standard of care to every patient. And I'm wondering how people feel about that.
I do have someone who wants to be unmuted. So Linda, I am going to go ahead and unmute you. If you want to participate verbally, you can go ahead at this time. Okay, there might be an issue with Linda's audio. We're not getting anything here. Like I said before, anybody that has anything they want to contribute, go ahead and type it in. I did want to say we received an email from another attendee who pointed out that he does some volunteering with human trafficking awareness, and that a lot of transgendered people, they have an increased risk of being trafficked. And so he wanted to bring that to the attention of the group as well, because as nurses, we know that sometimes we see these folks and we might be the first person that notices that something is off, and that they might be a victim of human trafficking. And so just another component of things to be looking for.
A lot of times I see patients, this is Sue Painter again, a lot of times I see patients on the consult liaison team that come in after a suicide attempt. And, as I look back, I think about when I was talking earlier about safe spaces, that they already feel so overwhelmed when they come in on a hold for mental health because of the overdose or the attempt on their life. And then I've seen them get more depressed during the time that they're in the hospital, because the very things that they're experiencing on the outside, they feel in some ways is happening on the inside. And their depression actually gets more intensified at times after a suicide attempt, just from the way that they are not being cared for.
Yeah, that's a good point, Dr. Painter, that people are coming to us for care, and in a sense, we can make their entire situation more stressful and more upsetting. And we ideally want people to think that hospitals and healthcare offices are safe spaces. And it might just be things that we don't consciously realize we're doing, whether it's our nonverbals or things that we are saying to these patients, that it's driving them away and making them not want to seek healthcare. And I know the article talked a bit about the lack of healthcare and insurance and access to care that these patients have. And, you know, even if they have the access but they don't want to seek help, that's just as detrimental, I think.
One other interesting aspect I think about the video that I think is mentioned in the article as well is, I guess, the interaction between the two nurses. If you'll notice, you know, one of the nurses appears to be more experienced, more seasoned, and has had more longevity on the floor. And I just think the powerful influence that we can have over our peers, you know, if this man is younger and has less experience, you know, how important it is that we mentor and enculturate our peers into the profession, you know, and encourage them to seek cultural competence for really any patient population. And I do think that he did his best to stand up, but I think that it just reminds me that how important it is about mentoring new people into the profession.
To add to your point, David, I did receive a message from Linda Council, and Linda says, in addition to the very dramatic demonstration of the inappropriate and almost cruel dialogue, the complexity of issues which influenced the nurse's behavior were multiple and complex, but they were inexcusable professionally, ethically, and compassionately.
You're here, yeah. So hopefully everyone did notice that. Another thing I'd like to point out, and Dr. Painter, this is certainly something I've learned from you and we've talked about, is that, you know, the patient has a medical diagnosis. And I guess one of my pet peeves is when a patient is on a medical surgical floor and somehow, because of the concerns of the medical condition, in this case it would be oxygen or respiration status, that their psychiatric diagnosis just gets completely pushed, you know, off the radar screen. This patient had major depressive disorder with a history of suicide attempts, and if you notice, the one nurse said, you know, they're not serious attempts. And I must say that, you know, any patient with a psychiatric condition, we need to manage that condition as part of the patient's plan of care, even when they are on the medical unit. And I just think that any suicide attempt should be taken seriously, and we need to educate students and our colleagues about that. So the patient ultimately, based on this horrendous treatment, as Linda Council just said, it's cruel dialogue, you know, was really pushed to the edge and had concealed some, you know, medication in her wig, and completed has done an act of suicide or attempted suicide on the unit. So luckily, the real Miss Wertz did survive, in case anyone is wondering. But I just really think that we can do a better job of also managing conditions, our patients' psych conditions, regardless of the practice site.
And I'm just wondering too, with the other nurses that are on the line, how these issues are being handled in your facility. Like, is there workshops? One of the things that I learned the most about the article is that nurses feel uncomfortable in approaching and working with these patients, but what can we do as far as education-wise and support to help each other advocate? Because it seems like from the video, one of the things that was clear was having difficulty with confronting this woman in the moment. And we all know, as it said in the article, that these comments go on in the nurse's station, in the break room, and in this case, within earshot of the patient. But what are we doing as universities and hospitals to support nurses to have a better understanding and have a place to discuss these issues?
So Linda, this is Kelly at ONA, and I think what you're bringing up is exactly why we're having this activity today. I don't think there has been enough attention because it is a very complex issue, and as you know, in the hospital setting and in the school, you know, we also have to make sure everybody knows the sepsis protocol and you know, the fall prevention, and you know, there's just all these things that, you know, are NDNQI measures and things like that that really get the focus. And so that's why we felt it was important for us to bring this opportunity of education, and we're so grateful for the work that you and David are doing today because it is a real need. I also just wanted to put a plug out there for, you know, there are really great, and I'm sure there's other providers that are doing really good work, but we've had the opportunity to work with a group called Equitas here in the Central Ohio area. We haven't done any continuing education with them, but just learning about what they're doing and how they're serving the community. And I know that they have a goal because they serve the LGBTQ community, and they have a goal to provide continuing education to nurses in the future as well. I don't know where that's at right now. It's been a little while since I talked with them, but a good thing to Google if you want to see some of the things that they're doing and some of the unique ways that they're serving LGBTQ patients.
Yeah, I don't remember when I worked in hospitals and organizations around here that we've ever had any sort of workshops or classes or really anything offered to us. And it seems like such an obvious thing because we know that there are so many complex issues, but yet it's just been something that was never addressed, at least in organizations where I've worked.
And I think you both bring up a really great point. In the article, there's a section that a theme was identified in the qualitative interviews called circuitous answers, which means that many times I think those who were interviewed, like the nurses and so forth, gave rather rambling answers because they just were unsure as to what the right answer would be. Mm-hmm, so right. sometimes I think as nurses, we're really, really worried about presenting ourselves as being competent to the point where we're almost afraid to stop and say, I don't know the answer to this question. I'm not culturally competent and I need to go and find out. But I do think that there's a sort of a salve that is universal, and that salve is common courtesy. And I think that any patient population, any person with whom I come into contact, I mean, has the right to refer to themselves as they would like to be called. Mm-hmm. They have a right to their belongings being handled respectfully. They have a right to that standard of care. They have a right to see their visitors and have their visitors, you know, treated with basic courtesy. And I wonder if we could just even agree that that's a great place to start. I think it is a great place to start.
Absolutely. Roxanne, you are unmuted, so if you want to go ahead and comment.
Are you able to hear me?
Yes.
Okay, so I did want to comment because I live and work in the Philadelphia metro area. And my first position in an acute psych hospital, part of the orientation program was cultural diversity training, and that included how to interface with the LGBTQ community, if I'm saying that correctly. And the standards of the facility was, during the orientation processes when new employees are oriented to the culture of the organization. And it was at that point that we were educated on how to treat everyone as a patient. And then anecdotally, we could see, it was clinically evident, the poor outcomes that this community had, as evidenced by the recidivism and the high suicide rates. And so there was just a culture of compassion and understanding for the stigma attached for these folks. So, and then not only during the orientation process, but we had updates every year, education updates, and the staff was re-educated and had to sign off on, as a facility, how we would approach everyone who came through our doors, not just members of that community, because other mental health diagnoses receive equal type of stigmatism. And so that's pretty much the culture here in this area and other facilities that I've worked at. Members of the LGBT community have always been treated with, I would say, extra compassion because of the poor outcome. So that's my input on the topic.
Thanks, Roxanne.
Mm-hmm.
This is Amy from the ONA, and Roxanne, I do agree with you. I think that the facilities that I've worked in the past, we did do diversity training in the orientation time frame, but I think that it also comes from the environment that in which you work, because some hospital systems are trying to change the questionnaires and, you know, the things that are like in EPIC, you know, when they admit a patient, they're trying to change the language, but it also needs to there needs to be some kind of training so that nurses can stop another nurse from being involved in saying things that are hurtful.
Mm-hmm.
And there is that fear of that nurse setting up a, being confrontational
Mm-hmm.
and having to deal with that. And so there needs to be some training in how nurses can stop it, nip it in the bud.
Yeah, so I'm just going to hop on to what Amy said. And here in Central Ohio, some hospitals are asking preferred pronoun questions upon admission. And I unfortunately was a patient recently, and the nurse who was doing my intake, I saw on Epic that they had the preferred pronouns, and I had asked her, oh, well, no one had asked me about that. And she said, well, someone must have, because they charted that you are female, you identify as female, and you're a she. And I was, kind of arguing with her. I said, no one ever asked me those questions. I said, it's correct, but if it wasn't correct, she wouldn't have asked me. It was already charted. And she was trusting that the other nurse had accurately charted the right information. And it just, I was grateful that I wasn't in a position where I needed to correct that. I would imagine that would be really distressing and make me very untrusting of nurses and the healthcare organization. And, she ultimately had sided with the other nurse, saying, no, they did ask you, you must be mistaken. And, I'm not mistaken. I would remember something like that. So it just made me realize, all of the opportunities that nurses have to do the right thing, ask the right questions, and like Amy said, support one another, or at least call them out on, hey, you really shouldn't just assume before you chart something like that.
This is Sue Painter again. And I was also thinking about one of the things that was talking about the article is, that a lot of these issues are along a continuum. And I think that patients in general want to talk about it. And I do think it's okay to say, what is it that you need from me and how can I best help you? And if you don't mind explaining to me where you are along the continuum, to give patients an opportunity to talk about their experience. because we don't know how we can best help.
Yeah.
And we need to ask.
And I think, Sue, admitting that is a big step for a lot of nurses. And I think what we saw here in this video was one nurse, the young man, I think really would have been the type of person who, it might have taken him a while to get there, but I think he might have actually been one of those nurses who would have said, okay, I'm going to see how I can really help this patient, but allowed himself or was shut down largely by the other nurse, which I think what she was doing in some respects was, I think, in a way, lateral violence or bullying rather toward the other nurse. Sometimes I think we need to really realize or recognize that providing culturally competent care does take courage and does take a lot of initiative. And even though our peers might be telling us, don't bother, don't do it that way, just get in the mud puddle with the rest of us and stay here, it does take courage to do the right thing sometimes.
This is Amy from the ONA again. I'm going to step out on a limb here, but my fear, because I do have a family member who is transgender, and the experiences that she has gone through, I do worry about religious organizations, because there are situations in which in a religious organization, you're allowed to pray with the patient, you're allowed to express your views. And I worry about that with the LGBTQ community, because there, some religious foundations are, against that, the concept of homosexuality and transgender and all of that. And so I do worry. In the video, the nurse said, well, I don't care who knows it, and I have seen that where I've worked before, and I worry about that part of it.
Mm-hmm.
It looks like no one wants to follow up. I think that it's a hot potato. It's a hot button. I think that my fallback position and go-to position is, no matter really what, we really need to provide a safe standard of care to everyone. And I do think that we should have the courage to remind our colleagues if we see them going down a path like this. But I guess, we're watching a video, we're safely in our offices right now. But I think that, as the questions are going to ask us to do in the follow-up, the part of this continuing education is reflecting and doing an introspection and finding out, in the deepest recesses of our mind, what would we do if we were confronted with a very aggressive colleague or with a patient that we didn't understand, or a patient, what would we do? And so I think we all need to realize it's not always the other person that we need to think about, it's us. So I think I'm really looking forward to myself even, reflecting on this experience and the video and determining, exactly how would I react in a situation where I was dealing with a patient or trying to help a patient, and there was something about them that I had no idea, I didn't understand.
I have a comment here from Wendy, and Wendy says, in the recent gay parade in Cincinnati, she walked with her Episcopal church and haters were yelling at us for our competent views. And I think with that too, it does take some courage to not engage in that and not defend yourself. We all want to defend our own thoughts, feelings, and I don't care who knows it, things to say. And so it takes a little bit of strength and courage to not engage and make the whole situation worse. So and it's a very touchy subject, as we all know. it gets a lot of people hot under the collar. So
Yeah, and I think exactly. I think we need to move the discussion back to what David originally said, and in our ANA Code of Ethics, and you shared portions of the Ohio law, law and rules as well, as about we are to care for everyone with dignity, and I think we get into a really uncomfortable situation when we're pitting religion versus the other, because there's some things that are said and done towards religious people as well that are highly offensive.
Right.
So I think that if we all come on that common ground, where if we are stepping out in a space of where we are going to be respectful, whether or not we agree or disagree or whatever the case may be, but that you are a human being and that's what matters, and that the fact that you're a human being and that you are now we are in this caring relationship, that I'm going to honor who you are as a person and do my best to keep any type of other thoughts that I might have. Because it's just like we have the obese patient that we're like, man, what if they ate better their whole life? Maybe they wouldn't be in this situation with all these comorbidities. There's all kinds of things that we have our own biases and judges against. And so we really need to be careful to make sure that we're not, getting in a us and them kind of space about religious versus not religious, or how certain people respond or whatever, but just be that voice of, hey, this is a situation where we can show the dignity of nursing and how we appeal to our nursing ethics, regardless of our religious views or non-religious views or whatever.
I also think it's important to note, especially in my work as a consult liaison, this is Sue Painter again, that it's not only supporting and advocating for the patient in regard to the health care that they're receiving, but it's also important to remember that we have to deal with families. And I know that there's a lot of patients that have a lot of conflict within their families, and a difference in belief systems that we also are confronted with pretty heavily, especially when it's a difference than what our patients feel. So a lot of times I find myself advocating for the patient, but also being aware of HIPAA and some of the concerns that the patients have. I just know that I've had some pretty intense conversations with families who don't see it the way the patient does, and that when they're in again for a suicide attempt afterwards, it's a really fine line to walk between what the patient will allow you to talk about, especially after a suicide attempt, especially if it's serious enough that you have to first get them through this from a medical perspective, and yet they have so many emotional issues going on.
Dr. Painter, this is Kelly at ONA. Can you share a little bit more about that? One of the questions that immediately came up in my mind is, okay, so do you need to talk the patient through the fact that, okay, if they grant privileges for you to be able to discuss with a certain family member, that you may be revealing, the personal pronouns and things that maybe, because I can see where there might be some situations in our acute care facilities where this might be the first time family are hearing about this. And maybe the patient isn't thinking of the consequences of, call my mom and let her know I'm in the hospital, and not thinking through because of the trauma that they've suffered, or, the suicide attempt or whatever it is. So can you just give us some advice on maybe navigating that conversation?
Yeah, and again, it's going to depend on what the mental state is of the patient at the time, because we always have to protect that. And I think about a particular case that I had with a patient where he was very sick and he was unable to tell me exactly what he needed at that time. And the family kept coming in the room and getting really loud about what they thought that happened and trying to confront him about what happened, and he wasn't ready to talk. And so in that case, we asked the family to leave the room, and the charge nurse and I and the medical doctor went in and talked about what he needed right then to get through, because you're right, sometimes that is a moment where things begin to unravel quicker than the patient is ready for. And so I always just go back to the patient, or if they're not in a place where they're able to advocate, we might limit visitors for a little while until they're able to verbalize and kind of catch up to where they're at.
Thank you.
So again, I guess just follow up to the video. I just wanted everyone to know that all of that really happened. I saw it and it shook me up. I can't say that I did it for any noble cause or anything other than I felt like, I just wanted to talk about it. And I think the greatest legacy this very short, precious time that we could have together is one of the best things we can do for any issue is to simply talk about it. I think the worst thing we can do is to simply sweep it under the carpet and just ignore or not talk about any issue. So it might be a great tribute today after doing the reflective journal questions to this time together is to just have a conversation with a colleague about it and try to, at least keep it on the radar, because I'm sure it's on the radar every day for this very unique patient population.
Yeah, Dr. Foley, can you and Dr. Painter share, you guys are leading this and you guys are professors in your schools, and can you guys share some other things that your institutions are doing or things that you've heard? The authors of the study talked about a need for this type of education at the undergraduate level. How are you influencing these conversations, and any advice you have for us within our places of work, places that we work to influence these conversations?
Well, at the undergraduate level, I just wanted to share this video or this script. I actually brought the actors into the classroom, and I had about 75 pre-licensure students. And it was even a much more unique experience to see this done in a theater in the round concept live. And it was absolutely incredible. And I'm finding that the millennials in particular, who are the majority of our pre-licensure students now, are quite a tolerant group. I mean, to them, this was like something that, when I was in school 35 years ago, this would have been extremely shocking. But to them, I think they were far more empathetic with the patient. I would only say that the best thing we can do for our colleagues is to, and as well as for students, is to remember that learning involves the cognitive domain, which is knowledge. It involves psychomotor skills, which nurses gravitate toward all the time. Who can start the IV the most and the best and the fastest. But we can't forget about the reflective or the emotional domain. That reflective learning and the affective domain is so important. We constantly need to be looking at our emotional response, our empathy, our skills of therapeutic communication. And that's a journey that will follow us throughout our nursing career. So we need to encourage that anywhere that we work. And Sue, I wonder what you think.
Well, I was thinking about a professor that I had probably 30 years ago who told us a story about how he rode motorcycles, and he would always envision that if he ever got hit, he would roll over the top of the car and land on his feet on the other side. And he did eventually get hit, and he was able to roll, fortunately, and land on the other side. And so the point in what he was saying is, when we're in situations where we don't have something to say or know what to say, then we don't know, and we just stand there and feel like a deer in headlights, and we're not quite sure how to respond. So one of the things I was thinking about is things that we can say when we're in situations like in the video where someone was really inappropriate. And if we don't have a sentence or two of what we can say, we are going to all just stand there frozen. And so that was one of the things that I was thinking about. And as far as what we're doing in education wise, I know that a couple of the students that are on right now are a part of a grant that we have at Metro, which is an integrated healthcare interprofessional and education and training grant. And also thinking about, we have social workers, we have medical residents and advanced practice psych nurses that are working together. And this is one of the issues that we're talking about, because if you get in a room with all those people, everyone has a difference of opinion. So it's a integrated plan to educate. We educate about a lot of things, suicide and mental illness and stuff, but this is also another issue that we'll be discussing. We also have a course on vulnerable populations that come up in the fall where we discuss this issue even further. And of course, in supervision, anytime any of our students have any patients that they are working with in practice, we're open to talking about that and supporting nurses to advocate.
I have a comment and question here from Michelle. And Michelle says, I teach a BSN course on politics and policy, and they discuss care of LGBTQ patients. One of my students brought an article about the LGBTQ community at end of life that reported that members of the community feel like they have to go back in the closet at end of life to get the same level of safe quality care as any other patient. And she is wondering if anyone else has seen this in their practice or have any ideas about why this would be true in this care setting more than other care settings.
Well, I could actually offer an anecdote that might be supportive, but this anecdote was probably from 30 years ago. And that is that, many people, in terms of end of life planning, don't make their wishes known, don't sign advance directives and so forth. And so a transgendered patient I'm aware of from about 30 years ago, they had made no provisions, and their family from out of state actually came and was very legally able to claim the body. And this is a very difficult example, but they had the patients, it was a male to female, had the breast implants removed, gave her a haircut, and buried her in a man's suit. So in other words, they made the decision at end of life to return the patient back to their assigned gender. And it was very difficult, and the person did have a partner. So I guess at end of life, like any other patient, again, just going back to basic care is, I think it's important for, if possible, is for everyone to make their wishes known at end of life so that they can be carried out by friends and family. And if family cannot be supportive, then perhaps, designating a friend or someone legally as the person's representative.
Yeah, that's a super good point, David. This is Kelly from ONA, I apologize. I just recently came across an activity as well where the nurses have noted, especially in long-term care, the baby boomers who are, the older baby boomers who are now dying, are, those who, might have had, they've had statistics, and I can't recall where they're from, but you might be more aware that a lot of these patients die alone as well, because they don't have those relational ties, because they've been ostracized from their family. Maybe their partner has died, just like what happens with all elderly people. A lot of people are alone, but yet it seems to be more of a loneliness, and that nursing homes too. This is another space we need to be thinking about, that nursing homes are starting to encounter more and more, where there's a lot of animosity and feelings amongst the residents, and managing that, because now you might have had a bias towards someone being gay or transgender or whatever, and now you have to live with them and have to go to lunch or whatever it is. So managing some of that kind of stuff is another issue that nurses really need to be on the front lines of. How do you communicate that? And I'm sure facilities need to be looking at kind of what this article talks about too, when you have everything set up in that gender binary, how's that going to play out long term?
Anyone else from my class or anyone else have any questions or thoughts to share?
We're not having anything else in the chat box. So I think, how many minutes are we out?
We're at 12:54, so we took up pretty much all of that time that we had. I think this has been a great discussion, and I appreciate all of you who have shared and put your questions in. I think it's been a really great discussion.
Yeah, Dr. Painter and Dr. Foley, do you have any closing remarks for the group?
The only comment I have is, again, in order to successfully complete, and I know Jessica will go over this as well, but again, I would encourage you, there's a Survey Monkey survey that has the questions for reflection, and please complete those, because I think that even though we're going to end our live time together, the learning and the reflection does continue. So I hope that you'll invest some time in that and have a meaningful discussion about this with colleagues and friends.
Thank you, Dr. Foley.
And I would also just like to say that a part of workshops too is role playing, because that, you know, this is just one scenario of many, and we all have, you know, cases and patients that we've cared for that we could have done things a little bit different with, and we're still in places in our lives where we may not say the right thing all the time. But I think that role playing for staff is another area that we can continue to move towards, helping each other understand the process and how to better advocate for our patients.
Absolutely. Yeah. Thank you for that. And I just want to say we from ONA, we just are really super appreciative for the expertise that you have brought. And I'm just really grateful for how engaged the audience was. And thank you for chiming in and speaking up about your feelings. And then please let us know if there's, you know, you'll have the SurveyMonkey, you know, reflection like Dr. Foley shared. Please let us know if there's anything else you would like for us to do or need concerning this topic. We'd really love to hear from you. In addition, I just want to invite both Dr. Foley and Dr. Painter to know that we really look forward to hopefully working with you in the future. I think
Yes.
I think this would be really excellent to do again, if possible, or, you know, we can chat offline.
Yeah, thank you to the both of you. This was a really great activity. And like Kelly said, thank you to everyone who participated. And certainly if you think of questions or comments after the webinar, feel free to email me and I can pass them on to the appropriate person. And like Dr. Foley said, complete the reflective journal exercise in order to get your contact hours.
And I just want to say thank you to you guys at the ONA for being so supportive. This has been quite a process, and I really feel supported by our association. Thank you so much.
Oh,
Yes. Thank you indeed.
it was kind of like a wedding. Nobody would know all the stuff that happened beforehand. It went off without a hitch.
Yes. Thank you, everyone. It's been a pleasure.
Thank you.
Guys.